well over 100 people attending and more will be joining. We know that 400 registered, and I can see the numbers going up very quickly, which means there is a lot of interest on the topic of today, which is again to talk about health system transformation. And of course, in the context of today and the latest news, we are going to talk about health system transformation in the context of COVID. Because I don't know if you heard the cases. To be exact, we had in Ontario 313 cases. In the country, 500 and something. So we are well ahead of the pack, not in a good place. You will see within the slides that I did put a couple of, we did put with Susan a couple of tweets that relate to a tweet that I did. Also, the previous Lieutenant General, the Honorable Only, also tweeted. When people of that stature start to send messages that is mind-boggling, that we don't take faster action, I don't know, quite frankly, what it will take. Several epidemiologists have spoken, RNO has incessantly spoken about this. And our concern, of course, is that unless we act very quickly to flatten the curve, which is not happening, and that means not only to continue to reinforce the usual public health measures of social distancing inside places and masking both in inside places that are not your home, as well as masking in crowded outside spaces. It also, in addition, means measurements that the province should be taken and that we believe at this point the province is faulty in not taking. For example, another strip club 2 days ago had significant issues. We know that karaoke and public health officials in various places and epidemiologists have pointed to that, so have we. When people sing, when people are loud, when things are dim in a bar, people speak louder. And if any of you heard Dr. Fauci, who we should listen to him very carefully, and we will send you a tweet that he sent it around, then we need to start to pay attention. So for the almost 150 participants and more that will be joining, we will ask you to take action. We will ask you to share your thoughts and concerns. RNO is not advocating to make any alarm system going on, but we are concerned that if we don't start to push the alarm bell, things will go from bad to worse. And that has happened in other countries, and we cannot afford it here. Just 1 second, I will let the dog out. With that in mind, we wanted to share why is it that RNO is so much advocating in general, not only during COVID, but specifically to COVID also, to take a primary care and a community approach versus what was the first round, which was mainly a hospital approach. Number one, as you know, not only we will have COVID amongst us, but we will have also influenza. So when hospitals every single year are saying that they're overwhelmed by influenza and we need to open surge capacity and add beds and our staff, etc., you know that that is happening every single year. Unless we're that because of the physical distances and because of the more hand washing, we have less of a problem with influenza. If we are not lucky, and the numbers so far are not showing that we are very lucky, then we will have not only the community not well prepared, but also hospitals collapsing. And when you do an analysis, yes, we did very well with the hospitals on the first round, but we did very well for COVID patients. We did not do very well for the remaining of patients with all kinds of things, going from cancer to mental health and addictions. In fact, hospitals did collapse because we needed to cancel everything. And we're not putting blame. We're saying that was the reality. So unless we start to expand our approaches to home care, to really doing our very best to keep people in the community, we are in for a challenging time come mid-November, if not before. We are going to share with you a bit about what happened in Balearic Islands, which is an island within within Spain that did better than the remaining of the province of the jurisdiction, a province, yes. They're called comunidades autónomas, and also the case of Cuba, which was mainly community-based, as always is in the case of Cuba. So that fits with our approach in general of strengthening community care, because it's well known to be a key feature of a high functioning health system in good times, and also it appears to be a good feature in difficult times. And again, when you look at places, also actually said to people, stay home. And they went a lot to the homes of people to take care of them rather than taking them out into mainly hospital pop-up testing centers and the such. We will then open for a discussion, for conversation of your thoughts of what you are seeing in your community. So we want to leave a good feedback. Thank you. Susan, the slides, please, or Olivia. I don't know who is managing the slides. Fantastic. Thank you so much. So the Balearic Islands is, of course, an island in Spain and includes Mallorca or others. I don't know if any of you has had a chance to be there. I have had the privilege to be twice there in different times during my life. And actually, it turns out, not because of that, but in coincidence, that they also became one of the best practice spotlight organizations. They were the first jurisdiction. The federal government in Spain became a federal best practice host BPSO, but then some of the jurisdictions said they wanted to move faster, and the Balearic Islands, which is led, by the way, by a Minister of Health who is a nurse, Patricia Gomez, which we can bring in the future for conversation if you want. She let become a BPSO. Next one, and they started with a system of public health. Public health works in general in Spain very much in touch with primary care. They're not so separate and distinct as they are in Canada and in Ontario specifically. So they led a team of public health and home care and primary care nurses, all of it together, with the physician and patrols that went to the homes of people to do the testing. They did a lot with people in their homes and really used the hospitals for very serious conditions. And in fact, very much like us, they were never lower than the rest of Spain. And as you know, Spain was pretty much not in good shape in the first round. Not is now in Madrid, at least. And they coordinated all the efforts, led by primary care, in touch with the with public health, and with very heavy involvement of home care services. Extensive testing and extensive contact tracing, isolation monitoring, and using of social media consults, and they did all of that mainly to the homes of people, a lot of that to the homes of people. So it's a system that usually is community-based, and it became so much more during COVID. Next one, please. Cuba is the second example. I do want to tell you that, again, I went to actually study primary care in Cuba, and it was many, many years ago. And it was very interesting because, of course, with my mind from here, I said, can we go and see hospitals? And they took me to the hospital, and I saw the hospitals empty. And I thought to myself, well, they're empty because, of course, with embargo, they cannot really, they don't have the supplies to do enough hospital care. Lo and behold, of course, my mind was completely wrong. This is about 30 years ago that I was there for studying that. And then they dealt with me and with the issues and doctors focusing on health promotion and disease prevention. So the model in Cuba has always been, partially because of the embargo, but partially because their philosophy is to do everything upstream, both from social determinants as well as from community care base. And they have a doctor and a nurse that actually live within that community and take care of that community. Even in those days that there was not a lot of technology, they had these big charts with everything about every family and what the needs were and where they needed to do more education, etc. During the pandemic, they did absolutely community embedded nurses and doctors again, but they also used, and this is something that I have recommended strongly here, and I will again tomorrow when I speak with health officials that are planning to share with us some of the plans for the fall. They actually use a lot medical students, nursing students, and pharmacy students to actually go to the homes of people and to do a lot of the health promotion there. And they're planning now to do the same with the influenza vaccine. And that is something that we absolutely should consider, especially that at least we know in nursing, not every single student is getting placements because of a variety of reasons, that many of them we believe should be overcome, because otherwise we will miss a generation, or, 1-2 years of nurses from graduating in time. But we could use many of these nursing students and medical students and pharmacy students and others to go to the homes of people and do the vaccination there. For example, for the elderly, right? For supportive housing, for many of the communities that are at risk, we could go and do the vaccination there. I need to give us an example that, Susan, I'm very sorry. I don't know what's happening with the audio today, but there is a problem. So let me, is it better now, Susan? Can people hear better? If not, someone else, I don't know if Irmagine or someone else is there, or one of my.
I think it's better, Doris, with your picture off.
Colleagues in policy can take it. Is it better? Can someone answer to me if they can hear me?
Yes, it is better, Doris.
It's nothing I can do.
Hi, Doris. I think it's better now. We can hear you.
Continue there. So I do want to give us an example before I move into ECHO. about Toronto East community partners, which is one of our BPSO HTs that involves South Riverdale Community Health Center, it involves BHA, it involves Michael Garron Hospital, and it involves several shelters and nursing talk a few weeks ago. And Olivia, maybe you can put the link to that specific capacity needs for this fall season. And they have really focused their efforts on vulnerable communities. And they have an entire plan well set up in terms of how they will reach the more at-risk communities, how are they going to go to the shelters, how are they going to go to supportive housing, etc., for the issue of providing the influenza vaccine. Because we are hearing that not all primary care settings will be ready to actually deliver the influenza vaccine the way that it has been in the past. And pharmacies also have on and off said yes and no in terms of delivering in pharmacies, as it happened in the last couple of years, the flu vaccine. So it is critical that hopefully all those professionals and sectors like primary care, like pharmacists that we consider primary care also, and like home care even, home care agencies, right? That they be ready to provide the influenza vaccine. So we have less people going out and being on lineups for an influenza vaccine, and being that their own homes, their own nursing homes, or their own supportive housing shelters, etc. This fits, of course, tremendously well with our ECHO 3.0 and also with ECHO 2.0 and 1.0, which were released, the first in 2012, the second in 2014, and the last one was released on May 12th of this year, which really speaks about, once again, anchoring the system in primary care with a much, much more robust community sector that involves home care, primary care, public health, etc., so that we can become a more balanced system and not always tilted to hospital care, which is the most expensive and not really where people live. People live in their communities. So it behooves us to really develop the services in the community. RNO was extremely pleased with where the system was moving with the Ontario health teams. And to a certain extent, we continue, except that now we are much more watchful and with question marks, given the recent announcements of government to open more and more spaces and nursing homes attached to hospitals, which by de facto will start to create a more hospital-centered approach to care, which is not what we believe based on the evidence from high-performing systems, what we need. We absolutely need strong hospitals. We absolutely need robust hospitals, but we need hospitals to do what hospitals are best to do, which is really the care of people that are with very complex needs for a short period of time, and then let the community, led by public health, primary care, and home care, and then all the other services like shelters that hopefully we don't need in years to come because housing will be better, but we always will need some of those other services. Let them really drive the anchoring of the system versus being anchored in what is an illness expertise and a very expensive sector, which is hospitals. Again, not to diminish the importance of hospitals, tremendously important, all of us know that, but the more we can move more and more and more care to the community, that's what people need, because that's where people live in. Next one, please. So let's open a bit for conversation first. I would very much, and my colleagues, like to hear your initial thoughts. And what you can do is do two things, because we are at 140 something people. So first of all, you can write on the chat, do you agree with this type of vision? Is it something that you're seeing in your communities? What examples can you give from your own expertise working either with other countries or other jurisdictions in Canada, or with your own jurisdiction if you work in a community setting or in a hospital that really is pushing for community involvement? Let's open for questions, and also if someone wants to share a bit, Olivia can promote you to panelists, and then we can also see you and you can share. Irma Jean, I know that Susan doesn't have a voice. She lost her voice for a bit. So if Irma Jean or one of my other colleagues, Olivia, can tell us if there are people that would like to share their thoughts first.
Yes,
Yep.
okay.
And you can use the hand in the chat line. If you want to speak, you can use the hand. Are there any questions or comments, Irma Jean?
There's three, I think there's a few here. Let me just see. No, not yet.
Irma Jean, we
give some
cannot hear
time.
you. I think you are on mute.
No, I shouldn't be on mute.
No, I can hear you, Irma Jean.
Okay, good. But I see a question
We,
here
Irma Jean,
from,
we cannot hear you.
I think others can. Well, everyone else can hear me, Doris.
Oh, you can hear? Okay, I cannot hear, but that's
Yeah.
okay.
So we
I cannot hear at all.
Liz who's saying she's disappointed we don't have more community testing at more convenient places like the pharmacy and more tests. What about the sputum tests that CBC advertised this week? How does that compare to the reliability of the nasal swab? That's one question, which is a question. Now, this one maybe is more along the lines Doris was asking. I agree, as a community-based nurse, that home care is very important in keeping hospital admissions under control. Question, I'm just wondering if RNAO is aware that despite the pandemic, communities are struggling with home care. Local hospitals are laying off nurses, and LHINs and community agencies are struggling with staffing, likely because community remuneration is generally poor. And this has absolutely been addressed in ECHO. I don't know, Doris, if you're getting the gist of this question, but it's certainly one of the recommendations in ECHO, the model Doris is talking about, where we talk about remuneration across all sectors has to be at parity with hospitals. That's the only way we're going to get reasonable employment across all sectors. I don't know, Doris, if you wanted to add anything to that, or if Doris can hear. Shall I carry on, or have we lost everyone?
Hi, Irma Jean, I can hear you. I think
good.
you can carry on. Yeah.
Okay, it's like a vacuum out there. Okay, here's from Laura saying, I work in primary care and have difficulty with privacy when I want to communicate with public health, etc. Laura, can you talk a little bit more about that? And maybe we can promote Laura to a panelist.
So I've just added Laura, and I'm going to ask her to unmute her microphone just so she can join the conversation. Oh, there we go. Hi, Laura.
Hello. I just mean that I agree 100% with Doris that it should be based in primary care, and that all the other home care agencies, public health, should all facilitate together to provide the best care we can for the patient. But the trouble that I run into is that everywhere you turn when you want to try to communicate with somebody, the Privacy Act gets in the way. And I have trouble with that, you know, with public health. Will they have to have the patient ask for the information, you know, not me ask for the information? Or so it seems like there's a roadblock in that sharing of information to try to do what is best for the patient.
I don't know, do others have other experiences there? It certainly seems like something that with the virtual care being offered through COVID, many nurses, in particular NPs, and primary care practitioners seem to have been able to overcome. Any comments out there that might be able to help Laura? I'm just looking to see if anyone has responses.
Are we good?
We're just answering this question. Okay, Melanie has indicated some places have clients sign consent, some don't. We're talking, Doris, about privacy.
Yeah, no, I heard because my computer crashed and now it's good. And I connected via Susan, so I did hear. Imagine, I think that while it's the case, what you mentioned, that with virtual care, the possibilities for nursing are better than before. I think still from a government perspective, quite frankly, the government is not favoring community care. Like if you look at what happened during COVID, right, was not only the issue that they can provide virtual care, they also needed to go to homes of people and was not enough PPE. So until a government, whenever that will happen, hopefully in our lifetimes, will decide that hospitals are important for what they do, but not to be the center of the universe, and that the center of the universe should be where most people live, which is in the community, which then means a mix of public health, primary care, home care, and other support services in the community. Until that happens, we're not going to see, I'm quite convinced by now, we're not going to see sufficient shift to care closer to your home, in your home. You know what I mean? And I do need to say, and I say it with sadness, and I know that many of you share that I was very hopeful. I was, for the first time, very hopeful that we were moving there. But when you see an announcement after an announcement after an announcement of more and more and more funding that is centered around hospitals for nursing homes attached to hospitals. Today, more funding for hospitals. You know, then, I mean, the finances of a health system, universal or private, are finite. They're not endless, right? So if you put all in one sector and you never recalibrate, that's what you have at the end. Our concern from our NAO right now with COVID is that hospitals will not be able to respond likely this time. And we are seeing it already. Kevin Smith sent an email already yesterday with his concerns that the numbers in ICUs are going up. And we are not even at the beginning of the second wave. We are just starting to smell the second wave. And if we don't have home care supported to do its work, and if we don't have primary care supported to do its work, I'm quite concerned. I'm quite concerned. Some communities, like some of the communities that are community centered, like I mentioned, the East Toronto OHT will, but others that their mentality has been always, we will save the world from a hospital. I don't think they will be able to respond. I don't think so, but I hope to be wrong. I do hope, for the sake of Ontarians and all of us included.
You know, the more I look at ECHO, the more I think this is the solution. And I hope everyone online is really, really familiar with it and can spout those recommendations, because the answers are really there. Now, I want to look at a few other comments here. Believing that registered nurses' role in primary care needs to be better defined. Funding system should be adjusted to support incorporating nurses into the primary care system. Absolutely, and I think, Doris, you'd probably add, primary solutions for primary care
Exactly.
is still a watershed document.
And also,
around
Irma,
role.
you may remember the video that you prepared with RPNO, where defines the role of the AREN and the RPN. You may want to talk a bit about that. And primary solutions to primary care is super clear on that. Absolutely.
Yeah, and that still is on the website, and it is actually the role of RNs, RPNs, and NPs working to full scope in primary care and what that can mean. And it's various interviews with the full team, including administration in primary care settings, talking about the roles, but also how they got there, because it's not easy, and how they talk together, who does what, and how does this maximize scope for better patient care. So it's really worth looking at. I'm not sure where it is on the website now, Doris, but I'm sure if you
If you
look
Google,
at
you will
primary
find
care,
it.
yeah.
There is a question here about, now that the schools are reopening, will be any additional support in testing done in schools? So first of all, we can talk with you about the curriculum that we offer together with the public health leaders on that. Also, don't forget the 625 public health nurses that will be in schools. And those nurses will be focusing mainly on COVID. The discussion about will they be doing testing or not has not been finalized, because remember, if one of the children or young adolescents is suspected of COVID, it's not only that entire class that needs to be looked at, it's also families, right? So how do you engage that? I will be able to answer that a lot more next week, because tomorrow I have an update. So next week, or we can send an email. I'm sure I will be updating through the blog also. I am not sure how much testing will be done in the schools versus asking them to. It all depends how spread it goes, right? Hopefully it will not spread out. Hopefully, remember, schools is different than a hospital, right? Or a unit. Kids go to school supposedly healthy. And if they're not healthy, we're supposed to keep them at home, right? So let's hope that we can sustain this and we can keep the lead on it. If one looks at some of the pictures that I saw in the newspaper from BC of teenagers ready to go to class, and how they were back to back, and many of them without a mask or anything, it kind of concerns you a lot. So let's hope that here in Ontario we do well. It is a concern to us, the issue of physical distance. We have been saying to people all along, you know, stay home, stay home, stay home. Yet for people without a house, they don't have a home. And we're saying to people, physical distance, 2 meters, 2 meters.
About this, we're
And
starting.
in schools, they don't have it.
Out of the second wave, the numbers are going up.
Oh, sorry, is Laura, sorry, Laura, are you speaking? I just want to, before you speak, Laura, there is a comment here, and Doris, the role of the school nurse might be different in different units. The comment about rural areas, and perhaps in rural areas, they will be doing some testing, I don't know. But
I
you make
think
a good point.
the role, I mean, is really to tackle the issue of COVID. How it will be tackled is really pertains to the different communities that they will be functioning and what those public health units decide. Because remember, they're being hired and they will work out of the public health. So the chief nurses are very involved. I know I spoke with Esther Mogadan, and she told me they already had hired all of the public health nurses that they had been allocated, and she was super proud that not only they were all RNs, but they were all BSCN prepared as per the public health standards. So I know my colleagues, our colleagues, they're yours and mine and all of us, are doing the utmost to do what's best for their communities. And they will need to really act according to what's needed for that specific community, including the issue of testing.
So there's a couple of more questions or comments here. One is certainly reinforcing that primary care was on their own, talking about primary care practitioners. And that's exactly what we're saying, and what we're saying for second wave, we have to change the course. I think this question by Karen Towler, I love the idea of having students involved with vaccinations, a professor at a local community college. How can we move it forward? And Karen, we need to take this opportunity to talk about moving clinical practice forward, period. Students can do vaccination, yes. However, they need to get back into the clinical setting. And RNAO is working on that. And we'd hope to have your cooperation.
Imagine, before we move, I do want to answer to Liz. Hi, Liz McGorty. Two things I want to answer. One, I love it when people say our Doris. Yes, I am yours, all of yours. And so is RNAO. And second, absolutely, colleagues, the more voices, the better, especially if we have voices from the field, people from the field that feel powered, not empowered, because I don't think, quite frankly, you need permission from anyone, but people that feel powered to speak. I know that when I ask, again, I'm going to give Esther as an example, because a couple of times I have asked her, because I know that she doesn't get in trouble and she has, you know, a big stamina for pushing it. And it's tremendously well taken by the media, because the media loves when they hear people also from their local communities. So if any of you has the possibility, the desire, the interest, and you do not need to have any expertise, we have a whole communications team. We have myself and others in policy that will be thrilled to give you messages, to discuss the messages with you. You will adjust them, of course, to your own reality, of course, without getting into confidentiality of names of patients and things like that, because we don't want to be defending you through lab, and we will if you need, but we don't want to. And we don't want anyone to lose their job. And some have lost their job, unfortunately and sadly, during COVID. For doing the right thing, let me tell you, for doing the right thing, like not putting a person that was transferred from the hospital that had been tested with COVID, with the patient, with the resident in a home that was COVID negative, and the person said no, until we don't know the results, we shouldn't. And, you know, so we have lost people for doing the right thing. And we very much would appreciate if people are prepared to talk not only about problems, also about good things, things that are going good in your community. You know, to sustain the effort that will take this second wave, we need also good stories. We absolutely need good stories, encouraging stories, stories where a school is doing very well, or where a primary care setting or a home care setting, whatever, are doing very well, where, like I just mentioned, the Toronto East, and I'm sure there are others where they're doing very well. Toronto Western, we also heard, was doing very good, and several others. So any of you that is willing, please put on the chat your name and your email, and we will connect with you. So thank you for raising that, Liz, and absolutely yes. And thank you for calling me our Doris. I take it with pride. I take it with pride.
Very good. Okay. So listen, Olivia has, I think, promoted 2 people to panelists so that they could ask a question. Is that correct, Olivia?
Yep, we have Azra and somebody, just the initial H. So Azra, feel free to talk, join in on the conversation.
Hi, can you hear me?
Yes.
Good evening, everybody, and thank you for putting this great presentation. I'm really enjoying it. It's great information. Anyways, my question is, since I am basically a community nurse and long-term care nurse currently working for pharmacy, I am basically in the community and I know the value of nurses in community. However, the majority of nurses would like to work in hospitals these days, and they do not like to work in the community or in long-term care homes. My question is, what is RNAO doing to entice those nurses to work in the communities and to stay in the communities?
Is Catherine or Brittany on? I would like some of our next generation, new generation leaders to take to give an answer. Imagine, are they on?
I don't know if they are. Can you, they wouldn't be panelists, they'd have to tell us. Catherine or Brittany, are you there?
I just did a search of the attendees and I don't see them, so.
Okay. So I absolutely can tell you what we are doing, because we are doing lots. First of all, the fact, and let me make a correction, because in the last at least 5 years, we see a lot, including new grads, going into long-term care. Many of them are going into long-term care, some because they couldn't find work in the hospital, and others because long-term care is their love, and others because they want to move into management, and in long-term care, they can do that faster. And they are doing fantastic work. I know that we do NELA once a year. Many of them come to NELA, and it's amazing, amazing, amazing to see the super young generation of leaders taking the reins in nursing homes. So I just wanted to make that, because I don't think it's a story that has been told enough. That's number one. The issue with long-term care and community care is not that nurses don't want to work there. It's that the conditions for the last 20 years, I think, in nursing homes started with competitive bidding. We are talking Harris time, and never really stopped. The conditions in home care and in long-term care, when you are talking about compensation and benefits, and then staffing and support in your staffing, are not as strong as they are in hospital care, right? When everybody's saying, oh, long-term care needs to do better on IPAC, well, we will send the hospital. Well, of course they cannot do as good as a hospital, because they don't have the resources that we give to our hospitals. And I say our because they are ours, right? And the same goes for other things. You look at continuity of care and caregiver. When people in home care not all can get full time, and they work piecemeal from one home to another, then read in the blog another piece from Shirley Sharkey, where Shirley Sharkey and the head also of Bayshore and a few others, actually is Bayshore, VON, and Saint Felice, that have put a proposal to actually give full-time work and to have the nurse work the entire day with that same patient. Like if a patient needs to have 3 to 5 visits in a day, and each visit lasts this long, they want to be able to say to that nurse or to that PSW, you stay with that patient. This is your patient today and tomorrow and the day after, both for the continuity of caregiver, which is important to the clients that they have, for the outcomes that we know that they're better if there is continuity of caregiver, and for staff satisfaction. You go back, and I don't know, Susan, if you have handy the quadruple aim, but it really responds to that quadruple aim of, better satisfaction to patients, better outcomes to patients because the outcomes are better, better value for money because when you don't have complications, it costs less, and better job satisfaction and role satisfaction for the care providers. And that goes for nurses, PSWs, and anybody else. Mm-hmm. So I don't know if that answers to your comment, but, it's not that they don't want to, it's that, I remember when Premier Harris one time said to me and to Charlotte Nosgard and Judith Shamian, they were the president and president-elect of RNO, and we went to visit the then Premier Mike Harris. And he said to me, when are you going to bring men into nursing? And I said, well, Premier, more men and more women will come when the conditions in nursing improve. The same is true for home care and primary care. If the conditions will be better, people will go. No doubt about that.
Actually, there's a couple of other things I sometimes think about home care and public health and primary care. That is nursing in a more independent role than often happens in hospital. And sometimes I think there's a bit of a move in the system to keep nurses in a structured setting where they have been in the past rather than in some of the new settings where they work in highly independent ways. So it's something also to think about if you're an independent nurse and really want to use all your knowledge and skills. Some of these other sectors may be more conducive to your own work style and way of contributing.
I would like to comment on a question about technology without disclosing the full baby that is about to be born. You are going to hear more about what RNO is doing in the area of technology, including artificial intelligence, health technologies, and where we stand on that, what we propose on that. But definitely to Kay, that put the question in the chat, technologies, especially virtual technologies also, have a lot to do with the quality of care that can be delivered to people in their homes, with the access to care. Like if you look at some communities where you don't have enough nurses, enough doctors, enough anything, right? Technology can open access, democratize access to health services. So you're absolutely right. There is a lot that we can do. Imagine maybe you want to chat a bit about the e-health initiative that we did a few years ago. And now, without sharing all the rest of what we are doing with the next stage, you will hear about that very soon in October.
Well, I think a number of you might remember with e-health, one of the biggest things and strongest messages that I believe we were giving to nurses was learn as much as you can about how to work with technology so that in fact nursing can drive the technology and not the other way around. And that's always been my concern. When we don't have champions who are strong in nursing and understand enough about the technology to help shape it and co-design systems to really make it work for the profession. Then it turns to be the other way around, that we're pushed by technology. And certainly with eHealth, we prepared thousands of champions who became much more engaged and involved in eHealth in their organizations, helping to shape the system, and culminated that work with a best practice guideline that really looked at how nurses in all roles can contribute to the implementation of eHealth in their workplaces, where nursing is driving what happens, and in fact, where it supports better nursing care. So I want to, just having said that, move to H. Sorry, that's all I know of your name. And I think you were promoted too some time ago. H, do you remember your comment or question? Olivia, is H promoted?
H is, and I asked to unmute, but they did also enter it into the chat box. I might be able to find it again.
Meanwhile that you find, I want to comment to the colleague that wrote up, Melanie, about food care nurses. I just want to share that, my gosh, when the first question came out of a blog about food care, and then we said with Heather McConnell, we said, let's go and ask people if they want more discussion about food care. We ended up doing a webinar with about 250 nurses that work on food care. And it was inspiring, guys. Melanie, write on the chat if you are back to work and if you are serving your clients.
While Melanie, okay, while Melanie is doing that, I did want to comment quickly. Someone said, what's happening with the public health nurses in schools? Are they finding them? Are they being hired? And it's a resounding yes. They are finding many nurses to act in the public health school nurse role. They're finding registered nurses. And I think sometimes it's a myth when people see that we need nurses and they say, oh, you're never going to find them. So public health is nicely being taken care of. There are nurses who desperately want those roles and are really available to be hired. In addition,
and many of the ones that are being hired, Imagine, are actually also nurses that have already the expertise. So they're not even new to the field, which is exciting.
No. The other piece is long-term care. You may realize in our basic care guarantee, of course, we're recommending more registered nurses for long-term care. Yes, RPNs and PSWs as well. However, we get the question, where are we going to find the registered nurses? We've done an assessment. And frankly, looking at the numbers who are not working in nursing, who want to be, the numbers who want to shift to long-term care, the numbers who are not even working, who would like to work, we have come up with well over 7,000 nurses who could be employed in long-term care. Not overnight, but certainly over a few months period. And that's why I think Doris has just said that recently we pushed for August hiring so that there was time to get nurses for long-term care and have them fully available. It's never too late, but sooner the better.
Melanie, you are next.
Oh, thank you.
How timely, how timely. I had you in food care, but you're doing public health.
I know, but guess what, Doris?
A lot of skills.
Oh, I know. But also it's because of the nurse. I had sent my resume in April. Then, of course, by then I had a lot of time because I couldn't see my patient, my foot care patient. And of course I was calling them and making sure they were okay, if they had their grocery, if they have everything, and et cetera, because I'm in rural eastern Ontario. So, I cover Ottawa to Hawkesbury to Cornwall to Iroquois. So, it's eastern Ontario. So, but then they gave me a call for an interview in July, but I had started to see some of my patients in July. So now I'm juggling, doing 2 days to help them out, and then being on the road Wednesday, Thursday, and Friday. So yeah, and
So
finally,
Melanie, can we say that you're media ready for a story like that? Because that's quite a story.
yeah. So yeah, because I've done, and also they're amazed with all my experience, because I've been a home care nurse for so many years, being a manager for many agency. I taught at the college for many years also, and yeah. So.
Oh, terrific.
So, yeah,
So
so
you were telling about the orientation. Share a bit about the orientation.
Yeah, well, the thing is, I'm also learning a lot, because I'm on the COVID intake. So all the questions that are asked about COVID, that goes to the public health. Well, I'm on that team, but also I'm like, tomorrow I'll be at the assessment center to be able to do an orientation there. So so then I'll be doing other things than just answering the phone calls,
Were you there when the Prime Minister came, Melanie?
Can't remember.
He went, no, you would remember for sure. He went during Nursing Week to the Ottawa Public Health. We arranged a visit for him there.
Yeah, but see, I was, now I'm located for the public health in Cornwall.
Ah, so no, he went.
Cornwall.
Okay.
Yes.
So Melanie, are you a school nurse then?
Nope. Well, right now I'm with the COVID intake.
Oh,
So,
okay.
But,
okay.
yeah, but during the orientation, there's another nurse that will be on the school team. And because right now what's going on, and all of you know, is that all the public nurses right now, they all taking away from their work, basically, but are working in the assessment center, or some of them are working on the calls, but most of them are in Casman Assessment Center. So right now what they're doing is that a lot of every staff, like the speech therapists are on the COVID calls, like everybody is, not
cool.
all to their, their place of work or something like that. A lot of them are working from home. But the thing is, for the school they were talking about is that they're making some, a team. That's why, like, another girl that was hired at the same time as I did is on the school team.
Okay,
so that there
great.
be so, and a lot of the girls that were in school before are now taking all the calls. Like, so right now they're saying that soon they're all going to be going back to the school, because of course we're getting so many questions about school. Like, it's like right now it's like sometimes I laugh, because all the cases that comes in that I dealt last week, it's the same thing. Oh, my daughter has a runny nose, but I have to stay home. Everybody has to stay home till somebody gets tested. And it gets, it's a problem, because a lot of them are teachers, or some of them are working. And so, yeah, so it's something that, all the calls, all the information that we get, and
much needed role. And you need to know that RNAO is heavily involved in working with public health in developing that orientation program for the school health nurses. So we're delighted to have contributed to that. So thank you, Melanie. And should we try and see if H is here, or if we know her comments? Just that I don't want to leave her.
I did find the comment.
Okay, maybe you can share that, Olivia.
So H commented, for real health system transformation to occur, we need to understand why hospitals are laying off RNs during COVID-19. Why is the system, the Ministry of Health, etc., allowing this to occur during a pandemic? Nurses need more of a voice, and thanks to our NEO support, we can voice our concerns.
So let me answer. You are 100% right. And it's not only in hospitals, it's also in long-term care. I wish I had an easy answer. I honestly wish I had an easy answer. Because what we have done to show the evidence, whether it's the 70% years of RN effectiveness, which we shared and was in the media for several years already, and what we are doing during COVID, and what nurses are doing, and specifically RNs are doing during COVID. You know, I said this with sadness. I don't know if it's a gender issue. Sometimes I think it's just a gender issue at the end of the day. But the reality is that it's a very serious issue, because unless all the work of people like Linda Aiken, that writes about the impact for 30 years already of RNs versus any other category of nursing or anybody else for that matter, and other researchers like that, unless that research was all invented and data was not collected for real, which of course is ridiculous, then it's absurd, because it also doesn't hold true in terms of financials. Olivia, if you can put the link to the 70-year RN effectiveness, people should look up that, because in that database, which is a public database with about 650 articles that specifically look at the issue of RN effectiveness from a clinical, from an organizational, and from a financial point of view. It's also a myth to say that RN costs more, because they don't. Mm-hmm. Because when you save on complications and you do the real math, they don't cost more. So what else can we do short of screaming more? Quite frankly, if you have ideas, we will welcome them. Because we have lost a lot of ground when you look at RN per population. We are the worst in the country. We are the lowest RN per population in the country for the last, I would say, 4 or 5 years already. So 100% you're right. We just, and it's an issue that we meet with ONA, by the way, also to discuss. And now when you layer to that, the disastrous move of the college to maybe open the 3 acts that were protected for RNs for initiation, to give them also to RPNs, and it's not to diminish on the importance of RPNs. I have worked with RPNs all my life. We all value the work of RPNs, but there is a place and a space on when it's an RN, and the college says it, right? And when it's an RPN, and the latter is for stable patients with predictable outcomes, which is not what you have in a hospital today. And also, quite frankly, it's not what you have in a nursing home today. So I'm not saying do away with RPNs, but we are saying that this province needs to shape up with RNs. So all I can tell you is vote with your words. And this is not just this government. So I think take pen and pencil and paper and letters to the editor and get into the media, and every single RN needs to start to speak up. And quite frankly, also RPNs. We have RPNs at RNO that calls us with these concerns, because they don't feel that they are really prepared to do the work that they're being asked to do. And quite frankly, even we RPNs said that we have a shortage of RNs in the last few months. So I'm not sure what is it that government is not hearing. Maybe it is that we speak too much. Maybe it is that we have become too assertive. And when women become too assertive, And in this case, nurses become too assertive and start to say what's wrong in workplaces. Maybe the best way to shut them up, or to think that you can shut them up, is to do away with them. But that will not work.
No, we won't stop. But I think, Doris, that's a really good way that you put that about RNs and RPNs. Liz McGurty asked, RN effectiveness compared to what? And that's exactly it, Liz. It's compared to number one, nothing, no RNs, RNs versus RPNs, RNs versus PSWs. There's room for all categories. However, each category has a role to play for best patient care. And that's what the evidence has demonstrated over and over, that RN care, in particular, those complex situations, delivers better results. And in many cases, it's life and death results. So it's very important to heed. I just wondered, looks like Susan is ready for us to talk about
I am going to first put the link to that ineffectiveness, because I do want
It's there, yeah.
So is it there already?
Yeah.
Oh, fantastic.
Yeah.
Fantastic.
Yeah. And someone is, so action alert, then we have cheer, and before that, I think H is saying we must continue to really acknowledge women's issues as part of what we're always dealing with day in and day out, and continue to work on that. And I think on a positive note, what Doris has alluded to but not said, I think, is that now with COVID, what we're looking at are increased enrollments in schools of nursing, increased interest in many young people, people of all ages, in wanting to be where they can make a difference. And I really think that we have to heed that as we go forward and talk about nursing, and reinforce those positive pieces and the fact that many people want to join our club. Okay, Doris, action alert.
Oh, look at you. How are you?
What do you see?
Oh, Morgan with her son.
Yes,
Delicious.
He's so cute.
Can you say hello?
Hello.
Are you going to cheer with us?
Yes.
What are we cheering for? The Raptors, but they lost, but we still should cheer for them. Can we cheer for the Raptors so they get their hopes up? Can we?
Put one in your
Yes?
Pardon?
Does he want to cheer for the Raptors?
Do you want to cheer for the Raptors? No.
What do you want to cheer for?
You don't know?
We will cheer for more RNs. How about if we cheer for more RNs?
More RNs.
Okay, we will cheer for more RNs.
Did you want to talk about the action alert though, Doris, before we did that?
So thank you. So yes, there is two things that we want to talk.
Put
and
that
I don't
slide
know.
up.
I don't know, Susan, if you can put the slide of the tweet, which I must say I was beyond impressed on the tweet when I saw David Only retweeting our tweet and saying it's beyond absurd why government is not moving with this. So please do go to that tweet. And this is because of the 313 cases. And Dr. Williams was sharing with people that this should be a wake-up call and people should behave better. So that's when we tweeted what you see there. And it has taken a life of its own. I don't know how many people have retweeted, but lots, and the comments are equally good. So please retweet if you are on Twitter or put on Facebook, etc. And the other is the action alert. And the action alert is on the issue of a just recovery for all. and this is asking Prime Minister Trudeau to, in a sense, take over the issues of long-term care and create national standards, and then give funding, but funding that is tied to national standards. And we're proposing that the national standards be those that we have in the basic care guarantee that we put forward. And then the second is housing, because we cannot have a just recovery and say to people stay home, but many people don't even have a home. And the last one is the reinstatement of the a federal chief nurse officer. And I'm quite hopeful that we will see outcomes on all of the three. I don't know to what extent, but I am very much hoping that our work, which started in August, well, it started before August, but in August we wrote to the Prime Minister that is having a lot of good attention being paid for it, and a lot of organizations that are behind us too. So that is absolutely great. If the disgrace of COVID can help us solve issues for persons experiencing homelessness, hi Gloria. I say hi Gloria because she does awesome people with people that live in the streets. So thank you, thank you, thank you. Mm-hmm. And also for the people that we lost in long-term care, and also to have a permanent voice at the federal government as we used to have. Then maybe we are honoring people that we lost better, and also those that continue to suffer in the conditions they are better. But you know, as many have said, a society is measured on how we treat the most vulnerable amongst us. So this will be a good test to see if that works. So now we can cheer. We can cheer so we get everything that we ask.
Okay.
Oh, we need an L.
Do you have an instrument that you want to play?
No.
No.
You have to remember me.
Like this?
Yeah.
I grabbed whatever I could find. Here you go. The chicken scissors and the lid for the chicken soup. Okay. Grayson, you need to also clap. Thank you.
Say, cheering for more
Let's
RNs.
make sure that we get more RNs, and that we get the chief nurse at the federal level, and that we get housing so people don't need to live in the streets without a home, and that we get more staffing in nursing homes for our residents of nursing homes and for the staff that are struggling there.
Mom.
Yes, Grayson.
Thank you, everybody.
Thank you, thank you.
Thank you so much, Doris. Thank you, everyone.
Thank you.
Thank you all. Bye.
Good night.
And those that want to speak in the media, send us your email, so we can get you in a good way. We can approach you. Thank you.